So again, 3 talks for the group projects. The first speaker is Nate Braniff from Pfizer, yeah?
Pfizer, yeah.
So talking, we will both studied in Waterloo, so we're just connecting the. Okay.
Thanks. Yeah, hi. Today I'm going to present on behalf of our group here at Pfizer, and I think Blerta Strula, my supervisor, might join online and participate in some of the questions. But happy to be presenting today. Thanks for the opportunity. So just for context, I'm coming from the systems pharmacology group at Pfizer. And so this is a mechanistic modeling group, but it kind of sits on the spectrum between kind of academic systems biology and more applied pharmacometrics targeted at specific development questions. And so we sit in the middle. We work with kind of medium scale models, mostly ODEs, but much more targeted at thinking mechanistically, but much more targeted at answering applied questions in development. And systems pharmacology or quantitative systems pharmacology is this is just for context here, but it's just one of many simulation approaches that are used in development at Pfizer. But the kinds of questions we're going after are things like dose selection or estimation, clinical trial simulation for informing design, and predictive or mechanistic safety evaluation to help with development decisions. So that's the context for the work that I'm going to present today. And in this kind of analysis that we use with these mechanistic models, we're often working with virtual populations. And so I think some folks here will be familiar with that. But in the oncology setting, we're often working with something like a signaling pathway model for a targeted therapy. And in this context, we're thinking about parameterizing this model, a subset of the parameters we can imagine or understand and have evidence that they vary within a clinical population. So this is expression of given genes or binding rates for specific targets that may have mutations. And when we fix those parameterizations and simulate our mechanistic model, we can get predictions of clinical response. So things like tumor size or progression-free survival, which we want to then compare to actual clinical data. And so the idea with these virtual populations, we're looking for distributions of these mechanistic parameters that when we simulate the model on match the distribution of outcomes in a clinical population. In oncology, especially in solid tumor, where a lot of this work has been applied, that's we're really interested in is matching a time to event endpoint, something like progression-free survival, which can be complicated to link to the mechanisms. The mechanistic model, getting that to speak to something like progression-free survival involves some statistical considerations which are complex, but we really would like methods for that because it allows us to apply these in the clinical setting. Yeah, so today I'm going to tell you a bit about for context and framing of the problems that I want to present to this group. I'm going to talk a bit about our model here of lorlatinib, an ALK inhibitor in non-small cell lung cancer. So the model itself is a model of the signaling pathway here on the left. It has the drug effect on the signaling pathway. It's a simplified signaling pathway here that then is linked to cellular proliferation and a clinical model, a shell and core model of tumor growth. And so this model here for calibrating the clinical data has parameters related to signaling, linking those signaling nodes to proliferation, and then the tumor physiology. And the parameters that we vary here within feasible bounds determined by preclinical data and literature. And so as you do that kind of varying, you can get a pretty wide range in response in terms of tumor growth with respect to the therapy. And the goal here is to calibrate this model against clinical data, in this case, a phase 2 study of lorlatinib in non-small cell lung cancer. So here I've shown some of the endpoints from that study that we'd like to calibrate this model against. And I guess I'll just say, the rationale for calibrating here is that once you have a virtual population, you can use it to simulate new therapies, new like dosing schedules, doses, or combination partners. And so the goal here is to calibrate against this historical data so that we can use this prospectively to explore other therapeutic decisions that would be of interest in development. So for folks who maybe haven't seen this kind of, I think probably a lot of people here are familiar with this clinical data, but the structure of the data can be kind of complicated because we have time series per patient and in terms of tumor size, but these are truncated at different progression or censoring times for the patients. So it's kind of it's a time series data with a complicated censoring structure. And so instead of calibrating against that whole data set, what we really choose to focus on is best percentage change, basically a waterfall plot, and the dropout time. So this is the time of trial exit regardless of cause. And we can use these two endpoints. One is essentially a measure of time. The other is essentially a measure of tumor size change. And by capturing that, essentially, we're going to be capturing the correct growth rate distribution for this model. So in setting up these virtual populations, we start with the mechanistic structure, which we've kind of determined from preclinical experimental data. And then the model will be parameterized by things like the drug IC50 on ELK or basal GFR activation, which can kind of be indicative of bypass resistance. And as you vary the parameters in this model, under therapy, simulated therapy, you can get different growth rate trajectories. And the goal here is to then kind of select a distribution of parameter estimates that when we simulate these efficacy endpoints matches a distribution that we fit to this best percentage change and dropout in the actual clinical population. So there's complexities here, though, in getting this model to speak to the actual data set because there's other risks involved besides just the tumor size change. So dropout time here for definition, again, is the time of trial exit regardless of cause. And the censoring label here identifies whether that was due to progression or censoring. So it's a binary indicator per patient. And so when we simulate a parameter set, if it's a particularly resistant parameter set that we've simulated, we would simulate up to the RECIST threshold, 20% over baseline. And at that point, it's not really realistic to continue that simulation because that would be clinical progression for an actual patient. For a shrinking trajectory, we could simulate that to the end of trial. And based on the simulated tumor size, there's not really any reason why that patient would leave early. And so the end of the simulation would be the end of the trial or end of follow-up. And so if you just use these times and take the best percentage change based on those, it's not going to include risks of censoring, metastasis, death that really are important for actually matching the clinical data. And so this makes it difficult and kind of inaccurate to use those to calibrate against. So what we use here is a statistical approach, basically, where we consider truncating these tumor simulations at observed times from the clinical cohort we're calibrating against. So those blue lines represent actual times in the clinical population when patients exited the trial. And for a growing trajectory, the times available would be those prior to the RECIST threshold. For a shrinking trajectory, it'd be any time in the observed data set. And so this gives us a set of candidate times to evaluate for any of our tumor simulations. And we use a flexible fitting method. In this case, we used a Gaussian mixture fit, but we've also looked at things like a kernel density estimate to fit to the actual data to assign probabilities of these times to the tumor simulations. So for example, for that red trajectory, it bisects that joint distribution fit to the data along a certain curve, which then assigns probabilities to the various times that we can consider truncating that tumor at. And that distribution accounts for the observed risks of those times in the clinical population. So we'll probabilistically assign a time to one of those tumor simulations, and along with it, we'll carry forward the censoring label to imitate the censoring structure in the actual data. And so in this way, as we probabilistically assign times to these tumor trajectories, this is going to account for that uncertainty. And then when we match on distribution of best percentage change, which depends on the dropout time and the actual dropout time, we're going to be accounting for these other forms of risk and get a less biased estimate for the underlying mechanistic parameters that we're exploring as causes of this variability. So, yeah, so the way we use this technique basically is we start with a large plausible population. So these are parameter sets sampled at random between bounds determined from preclinical or literature work. That basically kind of sweeps the parameter space for anything that seems feasible in terms of the mechanisms. And then in generating that plausible population, we use this probabilistic method to assign times. And then we subsample from that plausible population virtual patients into cohorts of the size of the study that we want to simulate for prospective kind of evaluation. So if we're going to simulate an early phase trial, it'll be 30 patients, something on a very small scale. If it's for a later phase trial, you'd simulate maybe a larger cohort. But what you want to do is repeat this in a large batch of simulations so you can account for all the mechanistic variability that's contained in your plausible population. So we refer to this as a bootstrapping method, essentially. So the initial kind of mechanistic variability is determined by the plausible population, and that bootstrapping allows us to account for uncertainty in any realization of an actual cohort. And so shown here is blue is the actual data set with its confidence interval. And orange is about 1,000 virtual cohorts simulated for the same size as that data set. You can see you're matching on median survival, but you're also able to match the kind of uncertainty. And this approach is really valuable for doing prospective simulations. Now, if you change the dose, add a combination partner, you're going to account for the uncertainty induced by that mechanistic variability you've sampled at the plausible step, and your confidence intervals will be accurate, or accurate under the assumptions of the modeling approach, so that we can kind of be more honest about where we have confidence and where we are uncertain in terms of prospective simulations. And so, similar to the earlier talk today, we can also take this virtual population and analyze it in terms of what mechanistic causes are contributing to response here. So we can subset it on responder, non-responder on a given clinical categorization here. So it's 30% under baseline. And we can ask here which parameters are driving resistance most significantly. In this case, it was the bypass signaling through the pathway. But this approach is kind of general in the sense that we want to retrospectively look back at the mechanistic parameters we fit with this method to understand what's driving it. And we can use that also prospectively to think about how we might detect these biomarkers or design studies to understand these potential drivers. So that's the context in which we're kind of working. We're trying to calibrate these virtual populations against clinical data. The non-small cell lung cancer example is just one example, but this methodology is general across solid tumors, but also even across other modalities. And so we have a number of methodological questions about how to best to use this. And I think it has a math or numerical side to it, but it also has an kind of a clinical or biological interpretation element to it. So I'm not going to go through, I've prepared slides that I'll maybe expand on in the group. And we're group, I think, number 5 over there, if anyone's interested. But I'm going to kind of give you a high-level view in the time I have left of what these problems are. And we had 2 today. So we can kind of choose as a group what to work on, whether we want to work on both or home in on a specific one. So the first one is really, I think to make this concrete, it's really how many plausible patients and how many bootstraps samples do we need. So if you think about this framework, the plausible parameter sets really kind of determine the range of mechanistic variability that you're going to be taking into your virtual populations. And the bootstraps really are there to sample variability and prediction. So if you think about it, if you have a 30-patient trial, only 30 simulated patients are in each simulation. So there's going to be a lot more variability potentially in the outcome. And if you think about there being a fairly high dimensional parameter space of plausibles you want to sample, you may need a lot of virtual patients compared to actually a very large trial you're simulating to have that represented in those cohorts. So there's an interplay between the model structure itself and the complexity there and how many parameters you're varying and the number of plausibles you need and the number of virtuals you need. So I've built up, and I'll explain this again when we maybe whoever joins the group in detail, but basically I've set this up just for explanatory purposes as a toy model. And I think the real key thing here is to understand is that the identifiable subspace of your parameter set of that model that you're trying to calibrate it against clinical data is very important for achieving a fit. By definition, if the parameter is identifiable for the data you're calibrating against, it matters what that parameter is in terms of your outcome. The non-identifiable subspace of the model for that, with respect to that clinical data you're calibrating against, is pretty free. It is not heavily constrained by that data. But that doesn't mean that for projection, that those parameters are not going to be engaged by another combination partner, by a higher dose, by a slightly different, if you wanted to evaluate a mutation or something in that context. And so sampling this identifiable subspace is very important for achieving a good fit to the clinical data and capturing the observed variability in the clinical population. But sampling the non-identifiable subspace is very important for kind of accounting for the uncertainty or potential variability in the population in terms of those mechanistic parameter combinations that are not constrained by the clinical data. So thorough sampling of the initial plausible space guarantees that you've kind of filled up, what you want in terms of that is filling up both spaces. And what we'd like is metrics or diagnostics we can run when we're kind of building these pipelines to understand with respect to the given model and data that we're using, are we being honest, not just in, or are we effectively capturing not just in fit, but also in this uncertain dimension? And remember, the bounds here are constrained by other data sources like preclinical or literature data. And so we have information about the ranges that we're kind of trying to carry forward here, but we really want to make sure that we're kind of sampling that uncertainty or potential variability in the population here. So I've kind of walked through the toy example here. And for anyone who joins the group, I've also set up a simplified version of this model with some examples so we can kind of explore this in this setting. So I'll work through that with the group if folks are interested in that specific problem. But it really comes down to understanding that fit is not just the only metric we want to use here, and we want to have other metrics to understand that we've captured some of the mechanistic variability that's not going to show up just in fit. And so problem number 2 is really, I'll try to be quick with this. So it's how to properly select virtual populations against data from 2 randomized arms. So this is an issue we've been working with more recently. Sometimes we have access to data from 2 different arms. In this case, I've set it up as potentially 2 different doses. In an oncology trial where you probably don't have crossover, you basically, and if it's randomized, you can make the assumption that those populations in both arms are fairly similar in terms of their composition and mechanistic distributions underlying that. So what we really want in this context is a virtual population that allows us to simulate both arms, one population, one set of parameters, that when you simulate both therapies in the model, you're going to capture the endpoints that you want. Now, the problem here is that in actual clinical data, we don't ever observe patients in both arms. So we don't actually know. There's a counterfactual correlation that we don't understand. So I've explained how we do this in 1 arm, in 2 arms, and what we commonly do in 2 arms is assume independence. But the problem here is the model, being mechanistic, has some imposed correlation between the therapies. And it's reasonable that if 2 therapies target the same pathway or 2 different doses especially are targeting the same pathway, there's going to be a correlation response. Non-responders under a high dose are probably also going to be non-responders under a low dose. And correspondingly, those parameters will be resistant under both doses. So we have a kind of confined support that the model already kind of knows via the mechanism that's encoded in it, and assuming independence in terms of selecting virtual patients, the probability that they should be in the trial doesn't work. So we really need a method for accounting for that unknown correlation that's actually in the clinical data that imposes as few assumptions as possible, basically, in making that selection, while also kind of allowing for it. So this independence approach doesn't really work, and you basically cannot fit the tails of these distributions when you score on 2 arms. But if you score on each individual arm, you can get good fits. And so it's hard to select a virtual population for both of them. And those tails can be really important because those could potentially be your complete responders or the most aggressive non-responders. And so understanding the mechanisms in that tail are very important to us. And so I think I'll stop there. I think I might be at time. I've got some citations here I'll share with the group too. But those are the 2 problems, and we're number 5. And I don't know if we have time for questions, but if not, yeah.
Thank you. Thanks.